Good morning, good afternoon, and good evening to everyone. Welcome to the ISGyP Live Journal Club. Our theme today is Therapeutic, Diagnostic, and Prognostic Biomarkers in Gynecologic Pathology. I'm Becca Wolsky, speaking to you from University of Colorado in the USA, with co-moderators Ian Hagemann at Washington University in St. Louis, USA, and Natalie Benet is joining us as well from Cleveland Clinic. And we're very happy to have all of you joining us. Before we get to our programming, I'll draw your attention to the upcoming ISGyP Live events. On April 26th at noon Eastern Time USA, Dr. Blake Jilks will be speaking on the ISGyP Live podcast about the updated ICCR guidelines for reporting tubo-ovarian and primary peritoneal carcinoma, and that's moderated by Jacqueline Watkins and David Chapel. Also on April 26th at noon Eastern Time, Jenny Bennett and Rabina Wadi will be moderating the interesting case presentations by trainees or early career pathologists. So register for all of those events if you haven't already. A reminder that ISGyP Journal Club is global, with the Western Hemisphere occurring the third Wednesday of every other month at noon Eastern Time, and the Eastern Hemisphere occurring the third Thursday of the alternating months at 12 p.m. Melbourne time. So here's the schedule of topics through 2023. In May, we're looking forward to the Eastern Hemisphere group presenting a journal club on sex cord stromal tumors. We do offer detailed mentorship leading up to these presentations. So if you're interested in presenting at either journal club or interesting case presentation, please reach out to one of us via the emails listed here at the bottom of your screen. So for today's event, I'm very excited. We have 3 volunteer presenters today. Dr. Sam Amofa-Ho is a third-year resident at University of Florida in the USA. Next, we'll have Dr. Rodrigo Macedo. He's a first-year resident at Cleveland Clinic in the USA. And then finally, we welcome back Dr. Diana Jaravaza. She's a junior practicing pathologist at the National Health Lab Service, Tygerberg Hospital, Stellenbosch University in Cape Town, South Africa. So thank you to the 3 of you for volunteering. Here are the articles to be presented, and I'm going to ask each of the presenters to please read the title of your article before you get started. The objective for this journal club includes engaging trainees and early career pathologists, offering opportunities for presenting and moderating to members from all parts of the globe, providing mentorship and engaging future leaders like you all in the audience from around the world. Here's the outline and assignment that we offered to our 3 presenters. And here's our schedule for today. So we'll first hear from Dr. Amofa-Ho, followed by Dr. Macedo, and finally Dr. Jaravaza. As a reminder, we're in a webinar format, so please use the dedicated Q&A or question and answer for questions to the panelists with the option to upvote questions. And please go ahead and use the chat, hopefully it's enabled, to say hello to everyone and let us know where you are in the world. So now I'll stop sharing my screen, and Dr. Amofa-Ho, when I'm done, you can share your screen, and I'll ask the other panelists to please ensure you're muted, and you can feel free to turn off your cameras as well.
Okay, can you see that all right?
Yes, absolutely.
Okay, well, hello everyone. My name is Sam Amofa-Ho. I'm joining from Florida here in the United States. So I'll get started. So I have no disclosures. The paper I'm presenting is the efficacy and safety of Mirvetuximab Soravtansine in patients with platinum-resistant ovarian cancer with high folate receptor alpha expression, which are the primary results from the SORAYA clinical study. The authors are Matulonis et al., and it was published in the Journal of Clinical Oncology earlier this year. So as I said, it's the results of the SORAYA clinical trial, which was a single-arm phase 2 trial. The treatment was Mirvetuximab Soravtansine, and the patients had platinum-resistant ovarian carcinoma that had high folate receptor expression. So I just want to give a little context about the medication and about some of the trials that it's been used in previously. So I'm going to refer to it as MIRV from here on out due to the length of its name. It's an antibody drug conjugate, which I have an illustration of here. And there's three parts to that. There's the monoclonal antibody that targets the folate receptor alpha. There's the cleavable linker that attaches that antibody to the payload, which is a chemotherapeutic agent. In this case, it's DM4, which targets microtubules. So this medication was used in some other clinical trials, the first of which was Forward 1, which compared MIRV to investigators' choice chemotherapy in patients that had platinum-resistant ovarian carcinoma who had folate receptor positive cancers. And I'll kind of get into the more granular details about the folate receptor positivity in a second. There was no difference in the primary endpoint in that trial, but upon further analysis, looking back at the level of folate receptor expression, there was a signal that patients with high folate receptor expression might benefit from MIRV. To that end, more trials were devised with slightly different inclusion criteria, including SORAYA, which I'm describing today. The sort of sister trial for this is MIRASOL, which is comparing MIRV to investigators' choice chemotherapy in folate receptor high. And there's several other studies in other contexts. So here is IHC of the folate receptor alpha, which is, most cells don't have very much expression of the folate receptor alpha, but some cancer types, including probably about a third of platinum-resistant ovarian cancer, have expression of the folate receptor alpha. The way that it's scored for the inclusion in this study and also in the companion diagnostic for this medication, which I'll talk about in a little bit, is only cells with 2+ or 3+ membranous staining are counted. And for this study, they categorized the staining into either low, medium, or high based on the proportion of cells that had 2+ or 3+ staining. The study that I mentioned before, Forward 1, had slightly looser inclusion criteria in that it allowed any visible staining membranous at 10x in half or more of the cells, and patients were eligible. Whereas in SORAYA, it's only patients who had 2+ or 3+ and a high level of cells greater than 75%. So it's a little more stringent. So the inclusion criteria, as I mentioned, adult women with high-grade serous carcinoma of ovarian, peritoneal, or fallopian origin. Platinum resistance, they defined as between 1 and 3 lines of chemotherapy, at least one of which included platinum, that there was at least a temporary response to. And then there was recurrence of disease within 6 months of the most recent regimen. And then, as I mentioned, the high folate receptor alpha expression was greater than 75% of cells with 2+ or 3+ membranous staining. And patients in this trial had to have received bevacizumab as part of one of their prior lines of chemotherapy. Platinum refractory disease, people that never responded to platinum agents, were excluded. Patients with active or chronic corneal disease were excluded. In some of the early studies with this medication, there was a lot of ocular side effects. And so in this trial, they excluded people with existing corneal disease and then had did eye exams at the beginning of the study, and then had patients using artificial tears every single day during the study and using corticosteroid eye drops in the week after their infusion. And then patients that needed folate, which includes pregnant women, but all pregnant women were also excluded from the trial. So the primary endpoint was the objective response rate, which was calculated by the investigators using the RECIST criteria, which uses imaging to ascertain response to therapy. And all of the patients received either MRI or CT within the 6 weeks leading up to the beginning of the trial, and then, within the 4 weeks leading up to the beginning of the trial, and then received imaging every 6 weeks while they were on trial. And they followed up to 5 target lesions, and the change in the sum of the sizes of those target lesions is how response was determined. And there were several other secondary endpoints that were followed as listed here. The study was kind of the objective response rate was compared to some historical controls from a variety of clinical trials that use single agents either in phase 2 or phase 3 studies earlier between 2001 and 2014. And in those studies, the response rate was between 4 and 13%. And so the comparator that the investigators for this study chose was 12%. And the treatment regimen was infusion every 3 weeks. So the results, they screened 467 patients. And so this is something I want to highlight, that only 36% of the patients had high folate receptor alpha expression. And then after you exclude the rest of the patients that failed screening for whatever other reasons, 105 patients ended up receiving the treatment and being evaluable for efficacy. So objective response rate was 32.4%. You can see the confidence interval there. That was 34 patients out of the 105, and 5 of them had a complete response, meaning that all of their target lesions disappeared. And if any of their target lesions were abnormal lymph nodes, then those shrunk back down below a centimeter. And then 29% of patients had a partial response where the sum of their target lesions decreased by at least 30%. And then 48 other patients had neither significant increase nor decrease in the size of their target lesions. So then in the 34 patients that responded, they on average, before they had a recurrence or death from disease, had 6.9 months duration of response. Safety, there were quite a few adverse events, but most of them were mild, thankfully. 9% of patients ended up having to discontinue treatment due to an adverse event. And the most common were ocular adverse events, although thankfully no one developed serious ocular complications, which I think is in part due to the sort of preventative measures that were taken. And then you can see the other adverse events that occurred here. So this curve shows each bar is for one study participant, and the bar represents the target lesion that changed the most in size. So the ones over on the right side of the screen are participants whose target lesions shrunk. And you can see all those ones that shrunk 100% in blue at the far right are the participants that had a complete response. And then as you drift over to the left, you have the people that had partial, then stable, and then people that had progressive disease. And amongst the 34 people that had either partial or complete response, this is a Kaplan-Meier curve from time to recurrence. Survival is a little misleading on the bar graph there because of the 6.9 months median was the median time till recurrence. So to discuss the results a little bit, these results were sort of what was expected based on Forward 1 and based on the after the quote unquote negative trial, trying to figure out maybe there was a group of people in the trial that benefited, and rescoring the IHC on some of the people and kind of trying to figure out if there was a group that would benefit from this medication. Those are the response rates from the reanalysis of Forward in the patients that had with the stricter IHC criteria. And I should mention that Forward didn't have the bevacizumab requirement, so that's one other difference between the trials. So this medication ended up being approved by the FDA here in the United States back in November. And here is the approval. And the two things I would point out here are that it's required to select patients for therapy based on an FDA-approved test, the only one of which that exists right now is the Ventana full R1 RxDX assay. And the package insert for that defines positive and therefore eligible for therapy as greater than 75% membranous, 2+ or 3+ staining. And then the other two things that are different from our study is that there's no restriction to high-grade serous carcinoma, although most of the patients, I think, that are receiving, just statistically speaking, have serous carcinoma. And then there was no bevacizumab requirement, but that was part of the trial inclusion criteria. And I should mention real quick, Forward 2, which was a combination of bevacizumab and Mirv that had a lower folate receptor cutoff, I believe because it was conceived prior to the idea of having a higher folate receptor cutoff, had pretty promising results just published within the last couple of months. And so I think that kind of brings into question what the cutoff really should be, and depending on the context. So that's kind of something to think about going forward. And then Mirasol, like I mentioned, is kind of the adult sister of the SORAYA study. And so we're looking forward to results from that soon. So in terms of this study, strengths, I appreciated the strict criteria for the IHC scoring, and also the fact that the IHC scoring was described very precisely in the paper that was published in a primarily clinical journal. I admire what they did with the eyes and trying to prevent people from having adverse events related to their cornea. And it is kind of, generally speaking, for this medication, it's good that the companion diagnostic is available. I think in most settings as a send out right now, but hopefully that will, everybody that could benefit from this medication can eventually get that testing. Areas for improvement, I mean, they designed this study and a comparison two-arm study at the same time, so it's not really something that's unexpected. The study population was very homogeneous, and just kind of a general thing that, you know, the scoring for the folate receptor requires human interpretation, so there is a little bit of subjectivity in that. For us as pathologists, our main role, I think, kind of from this paper, is that we need to be able to facilitate and understand this folate receptor testing when it's needed to guide therapy. If we're going to be performing the testing in-house, making sure that the assay is verified well is critical. And then no matter where the testing is being performed, I think you know, as always, conserving tissue is paramount. And there is a question of using archival tissue from the original operation that these patients had versus having biopsies of recurrences. And there's a paper that I have in my references here that showed that pre and post treatment, the folate receptor expression for the most part stayed the same. So that is reassuring that we can probably use archival tissue. And that's what they used in most of the cases in the trial as well. And then, as I mentioned, with the results from Forward 2, that maybe the threshold, you know, the threshold may move around as time goes on. So these are some other references that I found helpful, and that is all.
Great. Thank you so much for that presentation and summary. It was a challenging article to get through. I thought you really communicated all the main points really well. I appreciate you choosing this article. Do you want to, we have, I think, 2 minutes or 1 minute before we should move on to the next. I don't see any questions in the question and answer right now, but I wanted to ask if you have any main takeaway point or particular point of interest, you know, for you personally.
Yeah, I think that the idea of sort of reevaluating our assumptions and reevaluating how we're looking at things, learning from the Forward 1 trial that, you know, the negative result from that, and then seeing maybe we needed you know, kind of using we loosely here, but that a stricter way of interpreting the folate receptor status might better sort of purify the group of patients that could benefit from this medication. And then going forward with the results from Forward 2, trying to think about, well, maybe that was too strict, and maybe there's another group of patients that would benefit kind of in between.
Mm-hmm.
So I think that's...
Yeah, and I mean, I think there is some degree of expression that's the optimal degree of expression. I don't know that we'll ever be able to fully evaluate, you know, for that one optimal degree of expression through the clinical trials, but yeah, any other questions? Ian, I don't see any other.
No, I think we can move on.
Yeah. Okay, so if you want to stop sharing your screen, and then we can have Dr. Macedo share your screen.
Hello, everyone. I hope you can hear me well.
Yes.
Okay, so thank you for the introduction. I'm Rodrigo Macedo, PGY1 here at the Cleveland Clinic, United States. So the paper I'm presenting today is a novel morphology-based risk stratification model for stage 1 uterine leiomyosarcoma. It's an analysis of 203 cases done by Dr. Chapel et al. So the stage 1 uterine leiomyosarcoma's clinical outcome vary widely, and there is no known accepted risk stratification system today. So the purpose of this research was to develop a risk score model that could better stratify patients with stage 1 uterine leiomyosarcoma. Inclusion criteria included hysterectomy specimens for leiomyosarcoma at Briggs Women's Hospital or hysterectomy pathology reviewed at Briggs Women's Hospital. Cases were selected as primary management only. Cases must be in a stage 1A or 1B FIGO at diagnosis. They should be from uterine primary site, and all Mirvetuximab and eosin stain slides should be available for review. As exclusion criteria, if any tumor was seen for pathological diagnostic consultation only, it was excluded. Also, leiomyosarcoma diagnosis was not confirmed, but on pathological review, those cases would also be excluded. And if any neoadjuvant leiomyosarcoma-directed therapy was performed, the case was also excluded from the cohort. Talking about the cohort itself, so the authors started with 1,177 gynecological leiomyosarcomas, and by inclusion and exclusion criteria, they ended up with 164 tumors in the study cohort. Those tumors were randomized into 123 tumors for the training cohort, and they ended up with 80 tumors in the final validation cohort after adding 39 tumors from external validation sources. As for the clinical data analyzed by the authors, clinical parameters included age at diagnosis, the primary site, the FIGO stage, presence or absence of tumor morcellation, and presence or absence of adjuvant therapy. The outcome parameters included date of first pathological diagnosis, the date and site of first clinical or radiographic recurrence, date of last clinical or radiographic follow-up, and the clinical status at last follow-up. So morphological data analyzed by the authors included the mitotic count per 2.4 square millimeters, which was roughly 10 high-power fields. This was taken as a binary parameter, either presence or absence. The count was performed on the most mitotically active tumor focus, and the cutoff was 25 mitotic figures per 10 high-power field. The authors also analyzed atypical mitosis. This was also taken as a binary parameter. The criteria to define atypical mitosis was if we had a mitotic figure that was multipolar, bizarre, or a ring spindle. And the cutoff used by the authors was 1 atypical mitosis per 50 high-power fields. Another morphological parameter included coagulative necrosis. This, as the other two past parameters, was also taken as a binary parameter and was defined as an abrupt transition between viable to necrotic tumor. Lymphovascular invasion was another morphological parameter taken into consideration, was also a binary parameter, and was defined as a tumor entirely within or protruding into vessels outside of the main tumor mass. Serosal abutment was another morphological parameter taken into consideration. As for the other 4 parameters, this was also studied and evaluated as a binary parameter and was defined as tumor invasion through the myometrium to abut the underside of the uterine serosa, in the fashion that myometrial fibers cannot be detected between the tumor and serosa, although the tumor should not be seen invading across the serosa. This would exclude the case. Additional morphological data analyzed included the tumor size, the pattern of myometrial invasion, presence or absence of cervical involvement, the relationship between the tumor and the uterine serosa, surgical resection margins, cytomorphology, and Brodler's nuclear ATPS score. the statistical analysis, survival, and risk model selection validation. So the p-values were all two-tailed, and the alpha threshold for statistical significance was set below 0.05. The primary outcome was defined as disease-specific survival and was defined as the interval from initial pathological diagnosis to death from leiomyosarcoma, death from other cause, in which case the data was censored, or the interval between the initial pathological diagnosis and the last follow-up, in which case data was also censored. As a secondary outcome, the authors used a disease-free survival parameter, which was defined as the interval from the initial pathological diagnosis to first clinical radiographic recurrence, death from disease, or less recurrence-free follow-up, in which case the data was censored. The risk model selection and validation. As for the risk model selection and validation, the authors built 12 algebraic risk models, and the candidate risk models were tested by the logistic regression. The risk model selected was the one that had the greatest area under the curve, and this model was then cross-validated. Results. The authors ended up with a risk model comprising 5 morphological parameters. Coagulative necrosis, if present, would be a score 1. Mitosis per 25, more than 25 mitosis per 2.4 square millimeter would be a score 2. Presence or absence, presence of atypical mitosis would also be a score 2. Lymphovascular invasion would be a score 3, and serosal abutment score 5. We have a score that goes from 0 to 13. Here we have the area under the curve for the training cohort when looking at disease-free survival and disease-specific survival. And both were statistically significant when you use the risk stratification model. The authors also used this risk stratification model to divide the patients into 3 risk groups. A low risk group in which patient had from 0 to 2 points, an intermediate risk group in which patient had from 3 to 5 points, and a high risk group in which patient had from 6 to 13 points. And as you can see from those Kaplan-Meier curves for either disease-free survival or disease-specific survival, we have statistically significant difference between a survival probability from each group when compared to each other. The authors also used this risk score, this novel risk score, to compare with existing grading systems. And for disease-free survival, you can see that there is a statistically significant difference between the area under the curve from the novel system and the existing grading systems. And you can also see that the area under the curve is higher using this novel system. For disease-specific survival, the same applies. We have the risk score has a greater area under the curve, and in the majority of comparisons, it was a statistically significant difference from the existing grading systems. The authors also built a simplified model for more Folate and myomectomy specimens. Those specimens are known to be hard to evaluate for lymphovascular invasions and serosal abutment. Thus, the authors built a score system that excluded those 2 parameters. As you can see on the upper right corner of the screen, we have the simplified risk score, which comprises coagulative necrosis as a score 1, more than 25 mitosis per 2.4 square millimeters as score 2, and at the presence of atypical mitosis per 50 high power fields as a score 2. The authors stratify patients between 2 groups, low and high risk, using 2 points as the threshold to divide between those 2 groups. And as you can see from those 2 Kaplan-Meier curves, and for disease-free survival, we have statistically significant difference between survival probability when comparing those 2 groups. For disease-specific survival, the authors argue that there is a trend, as you can see by the p-value. So strengths. This is an intuitive 3-tier system that helps providers and facilitate patient understanding of his or her disease prognosis of stage 1 uterine leiomyosarcoma. You can pinpoint and put the patients into categories that are now clear. You can interpret this score as a category that can be a little bit more clear than just having a stage 1 leiomyosarcoma. can have a stage 1 leiomyosarcoma. There's a low risk for recurrence, intermediate risk for recurrence, a high risk for recurrence. This risk score can also be used as a standardized basis for clinical trials, since the 5-year disease survival timeframe that the authors use to build the risk score usually approximates the median survival for uterine leiomyosarcoma patients. This study was performed with a methodological rigor, as you can see from the strict definitions of the morphological parameters, such as the atypical mitosis, the number of mitoses, the size of the high power field that should be used, the definition of serosal abutment. And finally, H&E, this is an H&E-based risk score. So this is a score that can be used in resource-limited scenarios in which you only have the H&E available for you. With good crossing and applying the correct risk score to the correct specimen, you can still extract prognostic information from those specimens. As for limitation and future directions, so the external validation cohort, the authors argue that there were few recurrences or death, which means that this warrants additional external validation. We had few outcomes to compare to the training data to the validation data. Also, the morphological review of in-house cases was performed by a single pathologist. And this points out to future need for inter-observed variability studies in order to be sure that we are applying and we are indeed dealing with leiomyosarcomas. I didn't mention it, but the authors combine non-spindle cell and spindle cell morphologies in their analysis. But they argued that non-spindle cell morphologies were rare, and thus the application of this risk scores warrants further validation in those scenarios. They performed a post-hoc analysis that indicated that the actual model indeed stratifies low and high risk patients in non-spindle cell leiomyosarcoma, but due to the rarity of those morphologies, this warrants further validation. Finally, no risk score is perfect. So even in this big cohort, we had low-risk tumors that carry a 12% risk of tumor recurrence, and high-risk tumors that had 9% patients who had no recurrence at all. So even though you are classified as the low or high risk, there is still a significant percentage of cases, the risk score may not apply perfectly. So this should also be taken into consideration. And this is what I have to present. Thank you.
Great, thank you. Really nice presentation. Is there a biggest takeaway that you want to share with us?
I think one that I kept thinking about is that this study is an ode to H&E. I mean, H&E analysis, if done with methodological rigor, you can still extract a lot of prognostic information from those slides. So you don't always need to, I mean, it is important, but you don't always need to use molecular or fancy immunohistochemical panels to extract prognostic information. If done correctly and with methodological rigor, the H&E slides also hide a lot of prognostic information and can be extracted.
Yeah, I mean, I totally agree. I think it's an admirable study that it's based just on H&E and really doesn't cut any corners. So I agree. And maybe with further external validation, perhaps will become more widely applicable or broadly applied, I mean, in clinical practice. Any other comments? Well, I don't see any questions in the Q&A. Well, we can go on to our next speaker. Thank you, Dr. Macedo. So Dr. Jaravaza, if you want to share your screen.
Good evening. Can you see my screen?
Yes, you're good to go.
Okay, thank you. So my name is Diana and I'm presenting from Cape Town. So the paper I was tasked to review looks at PRAME expression in endometrioid and serous endometrial carcinoma as a potential immunotherapeutic target and possible diagnostic pitfall. And this article comes out of the University of Virginia, and it was published earlier this year. So PRAME stands for preferentially expressed antigen in melanoma, which we know has become useful in the diagnosis of melanoma, distinguishing it from the most common mimics. However, it is not as specific as originally thought, and the list of tumors that stain with melanoma continues to increase by the day. So PRAME is expressed predominantly when it comes to benign tissues in the testis, but it has also been noted in benign endometrium and to a lesser extent in normal adrenal and ovarian tissue. So although PRAME hasn't been studied in endometrial carcinomas prior to the publication of this paper, there were studies that showed that PRAME was one of the genes that showed epigenetic alteration in the form of abnormal methylation in endometrial carcinoma. So the investigators conducted a retrospective study in which they stained endometrial carcinomas with PRAME to look at the expression pattern and to determine if there were any clinical implications related to their findings. So over a period of 3 years, they identified 256 cases, the criteria being that there should be sufficient wax block. They used the primary uterine tumor. Patients had to be treatment naive, so no recurrent cases or cases presenting with metastasis were included. They only looked at the endometrioid and serous variants, and morphology was used to assign the categories. There were less than 10% were serous carcinomas. They then went on to prepare tissue microarrays, and 4 punches were taken from each tumor wax block. P53 immunohistochemistry was used to further substantiate serous classification, and 10 normal control tissues were also used. When it came to immunohistochemistry for PRAME, they used the Abcam antibody, and they looked at 2 things: the intensity of staining, which was graded from 0 to 3+, as well as the percentage of tumor cell staining. For this study, they defined diffuse staining as more than 50%. A detailed Fisher exact probability test was used. Figure 2, which is taken from the article, demonstrates PRAME expression in endometrial carcinomas. And we've got 3 different tumors demonstrated in photomicrographs A, C, and E. And the corresponding PRAME nuclear expression is highlighted in B, D, and F, ranging from strong and diffuse to negative. Similarly, in the serous endometrial carcinomas, as demonstrated in figure 3, we can see the intensity of staining ranging from strong to negative nuclear staining. In terms of the results, they found that the average age of the patients in the study was 63, with patients having serous carcinomas being slightly older, as would be expected. In terms of grade, the majority of endometrioid carcinomas were grade 1 tumors, and serous carcinomas are by definition high grade. In terms of the tumor stage, the majority of cases were T1, and in terms of the nodal stage, in the majority of cases, this remained unknown. Mismatch repair status was intact in 195 cases in total and deficient in 61. Their study found that at least 70% of endometrioid carcinomas showed diffuse staining and 76% of the serous carcinomas. And then 89% of all endometrioid tumors showed some staining, whilst the percentage was higher in the serous carcinomas at 95%. Reasons were not given for the tumors that did not show any staining. There was no statistically significant association between the percentage of PRAME expressing tumor nuclei and the pathological grade or clinical stage. So this paper presents a novel concept of PRAME immunohistochemical expression in endometrial carcinomas. And the conclusion of the study is that the majority of these carcinomas express PRAME. However, we don't know why some of these tumors are negative for PRAME, even though it is they constituted a small percentage. One of the other take-home points is that PRAME is not specific for melanoma in the female genital tract in patients with a pertinent clinical history where this may become an issue. Although PRAME-based therapy was not an intervention in this study, these authors wanted to investigate the possibility that PRAME-based therapeutic strategies could become a reality in these endometrial carcinomas. So what therapies or treatment strategies are available? The first is retinoic acid therapy. So retinoic acid binds to the retinoic acid receptor and signals processes that result in promoting cellular differentiation and inhibiting tumor growth and survival. Some preclinical studies have already been conducted in vivo and in vitro, which show some promise. In addition, the retinoic acid receptor pathway plays a role in adaptive immunity by controlling T-cell responses. So this creates potential for it to be used as for PRAME to be used as an immunotherapeutic biomarker. In addition, the investigation of plasmid and peptide vaccines that would induce an immune response against PRAME is in the preclinical stages, as is the investigation of using PRAME in immunotherapy combined with other immunotherapies that are already on the market. In terms of strengths and areas of improvement, I think the major point for me in this article was that this study was based on tissue microarrays, which results in only a small proportion of tumor being available for analysis. And the PRAME staining was categorized as a percentage of the tumor cells available. So as we know, tumors can show significant heterogeneity, which then would affect the percentage of cells that would express PRAME, for example. So maybe an area for further investigation is to actually use whole slides. The study was also limited to only serous and endometrioid endometrial carcinomas. So we don't know what the expression of PRAME is in other endometrial carcinomas, for example, clear cell. In addition, the majority of these carcinomas were of the endometrioid pattern and were low grade, whereas patients who are likely to benefit from PRAME-based treatments because they may not be suitable for surgery would more likely have higher grade endometrioid tumors or serous carcinomas with extensive spread. In that line of thinking, the cases used were limited to uterine confined tumors, and patients with metastases or previous therapy with recurrence were not considered. And this patient group may also be the one that would benefit more from additional non-surgical treatment. The cutoff for staining, for diffuse staining, was defined as 50%, although it was not, reasons were not given for why this cutoff was chosen, but further studies could look at a cutoff that bears some clinical significance for further therapy. Although mismatch repair status was investigated in these cases, POL mutation status was not. And we know that POL mutation status is correlated to the responsiveness of tumors to immune checkpoint inhibitors. So that presents a further angle for research. I think this study could be used for further investigations of PRAME as a potential predictive biomarker and PRAME-based therapies in further studies. In addition, PRAME could be considered as a potential diagnostic marker in endometrial carcinoma, notwithstanding that we do already have some good markers in current use. And these are the references for my presentation. Thank you.
Thank you. That was fantastic. What was your biggest takeaway point or any point of interest from this article, Dr. Jaravaza?
I think for me, PRAME is turning up everywhere. That was probably the biggest point for me. PRAME is turning up in almost every tumor now. But I think this study has potential in terms of the therapeutic potentials, its use as a potential biomarker in those settings where these are available. I think in our setting, we're still far from that. So I guess for us, the take-home point would be careful of PRAME, its non-specificity in organs other than the skin. We just need to be aware of that.
Yeah, there's definitely two directions that deserve further study, right? There's the diagnostic and then therapeutic. For therapeutics in particular with uterine serous carcinomas, it may be advantageous, and we'd like to know more about that. And to be honest, I would like to know more about its specificity for diagnostic purposes as well. I mean, based on the endometrioid and serous, it's quite sensitive. And sometimes my cytopathology, I primarily do gynecologic surgical pathology. I have cytopathology colleagues bring me carcinomas of unknown origin pretty often, and I wouldn't mind another sensitive marker, but of course, to use it, I need to know how specific it is. Anyone else have comments?
Just want to highlight a comment that was made in the chat to the effect that this study can highlight the importance of crosstalk with colleagues across disciplines, including with our dermatopathology colleagues who might have considered PRAME to be a fairly specific marker of melanoma. Just want to highlight that comment, which is actually made by the study author. So thank you for being here.
Great. All right. So if there's no more questions or comments, I would really like to thank all of the volunteer presenters. Again, if anyone in the audience would like to do this, the moderators do meet with these volunteer presenters 1 or 2 times before the presentation. So we absolutely lend a mentoring hand and walk you through it. But if there's nothing else, we're done now, and that concludes our session. And my sincere thanks to everyone who's joined us today. Thank you. Thank you to the presenters.
Thank you for all the assistance, and yeah, thanks for having me.
Yeah, it's great.